G'day, it's Clint Patterson here, and I'm with my daughter Angelina. How are you, Angelina?
Good. Hi.
Today we're going to talk about intra-articular corticosteroid injections for rheumatoid arthritis. In other words, steroid jabs directly into the joints. That doesn't sound very nice, does it, Leanie?
No.
It's very painful, but there are lots and lots of reasons why we might want to do this. So we're going to explore that in this video. So what we're going to cover are the following things. First of all, who it is for. And I've got a little metaphor about how we should decide if this is a suitable treatment for us. Should I tell that story, Leanie?
Yes.
What have we got written here?
Who is this for? Metaphor bugs in couch.
That's right. I've got a metaphor for bugs in a couch. Now, what this means is that imagine a house, right, being your body. And Angelina, imagine if all the different rooms in your body are all the different joints. So it's like an enormous mansion. And you've applied some pesticide by taking a pill or something in your body that goes through the air conditioning unit into every room of the house to kill the bugs that are in all the rooms. But what if you only have bugs in one room? Then you're putting in something into the air conditioning unit that's going through the whole house just to try and affect some of the bugs that are only occupying one room. So what we can do in that situation is just attack the bugs directly, and we can go in and put an injection straight into that one joint that's not responding and really take care of the bugs in that room, because we actually have particles from bacteria in our joints that are coming from our bloodstream, from our gut. Did you know that?
No.
Inside your tummy, you've got trillions of bugs, and some of them enter into our bloodstream when we have something called leaky gut. So what's our next? So in other words, if you've got one or two joints that aren't responding well to your treatment, then perhaps a cortisone injection can be for you. So what about this next question?
What is an intra-articular cortisone injection?
Yeah, and what it is you either at the rheumatologist office or get a referral from your doctor and go to a special clinic where they use an ultrasound to find exactly where to put a needle right into your joint. And they put a whole bunch of steroid, which is this anti-inflammatory liquid, right into your joint. And when they put it in the joint, they really squeeze it in so the joint puffs right out, the skin expands, and it gets right in there to kill the bugs. And in this case, the bugs are inflammation, to reduce inflammation, and that goes right into the joint.
Where can you have them done? In my experience, variation in results. Systemic relief.
That's right. So where can you have them done? Anywhere you have a joint. So you can have them done in your feet, in your knees. You can have them done in your fingers, in your elbows. And those are the locations I've had them. And you can also have them in other joints as well. Anywhere you have a joint. And my experience and variation has been one that has both successes and also non-successes. So especially when I've had injections into my fingers and also my knee, I've had tremendous results over the years. In fact, before you were born, Mummy and I went to get married in Hawaii. And before we left, my doctor said, why don't you get an injection into your knee, because you'll be able to dance at your wedding? Because all the things that I had done over the last year before that couldn't get rid of the inflammation in my knee, even though everything else in my body was improved. But my knee would not improve. My doctor say, have a cortisone injection. And guess how long that lasted?
How long?
10 years. That's how long the injection helped me. It was great, right?
Yeah.
It only cost a few $100s, and it gave me years and years and years of relief. So that was a great one. Fingers have worked tremendously well for me over the years as well.
The science literature review.
That's right. Let's have a look at the science. Let's look at the literature review, because it doesn't matter what I say. Let's find out what the science says about this. Okay? So the science is actually surprisingly limited, given the amount of frequency that these injections are used. It's almost so widespread, the use of these steroid injections, that they don't do that many studies on them because they're so effective. They think we don't need to try and prove if it works or not. We can see that it's working. I had to go right back to 1990 to find a study that gave a risk-benefit assessment, and they said intra-articular injections with steroids may offer additional help in the treatment of inflammatory joint diseases. That's like rheumatoid and ankylosing spondylitis and so on. The major side effects are the systemic effects of the steroids, and what that means is when you put it, say, in your elbow or your knee, a lot of it leaks out of the joint, gets into your bloodstream, and the steroid goes all throughout your body. Now, if you take steroids on a regular basis, there's a lot of side effects of that, which is why Daddy does not recommend long-term taking of oral steroids, like even 1 milligram a day. Daddy's never taken those steroids because he knows that it can really affect the tummy. And remember I said before that if we mess up the tummy, stuff can get into our bloodstream, the bugs, right? And so we don't want that. But you get a little bit of that with these injections into the joints, and for a few days afterwards, your whole body feels really like better because it just leaks into the blood. And the other side effects include infectious arthritis, which rarely, if ever, happens. That's an infection at the injection site, which is, I think the statistics are 1 in 4,000. And cartilage damage. So you don't want to do these too often because there's a slight damage of cartilage. But Angelina, do you think it would be better to have inflammation in a joint that goes on and on, months and months and months and months, and really hurts the cartilage, or get just a little bit of cartilage damage by having one injection just once?
A little bit of cartilage damage, having one injection just once.
Yes, and that's what I think. If you've got one joint that's really bad and the rest are pretty good, then this could be a really good option. The study says these side effects are infrequent, which means not very common, and mostly preventable. Steroids are of little effect in radiological progression. That means if you go and get an X-ray and you have a look and see whether or not the steroid caused damage to your joints, it mostly says that it doesn't. And this is most important limitation of liberal use. Liberal means use all the time or freely. So you just don't want to do it too often. So they are a powerfully suppressant for inflammation and pain for a varying length of time, which depends on the preparation used. So there is variation. I had some sometimes on my elbows. It didn't do anything. Nothing. That's frustrating for me.
Yeah.
In some other studies, like those on juvenile idiopathic arthritis, it says that systemic, controlled, and prospective research is needed because there's not a lot going on in the area of research with these, but it's a safe and effective method for treating synovitis. So there's no sort of contraindication with JIA according to the studies, but more studies need to be done. Every study says that, Angelina. Every study says we should do more research in this area. Makes it look like they're not wasting their time with studying that. And because we never, ever know the full truth. We only get a portion of the truth every time we do some studies. In knee osteoarthritis, it shows that it's a effective treatment. And this study, if you're not watching online, but this is, I'm looking at the studies here in the video version of this. This one's called Intra-Articular Injections in Knee Osteoarthritis, a review of the literature. And then if we come to the very bottom, we always go to the bottom and look at the conclusions. And we see that it is an effective treatment, but there are some other treatments. And we'll talk about them in a second, because back on our slides that we're referring to, we're going to talk about those too. You'll be able to read them out in a minute. But again, further studies are needed, but it can delay surgical treatment, which is great. And then finally, here's a good study because it talks about basically these steroid injections into a single joint. And that's what we're talking about here for a non-responding joint. And the conclusion, or it says the clinical bottom line, See if you can read out. I'll read the first half, you read the second. The available evidence suggests that a single intra-articulate injection of steroids significantly
reduces pain, tremendous
tenderness
and stiffness, and increases mobility in patients with acute rheumatoid arthritis.
That's right. So pain, tenderness, and stiffness improvement. So if you haven't had a cortisone injection into a joint, and that joint is the only one that's really affecting your quality of life, the scientific evidence really suggests that this could be a good way to go. Okay, Angelina, let's go back to our slides, and then we will finish up our little video here.
Okay.
So we've done our literature review, and now it's time for this one. Any concern? That one. Read this out.
Okay. Concerns, pain, and frequency injection.
Systemic release.
Systemic release.
Now, we did well. We actually covered this already, I realized. So the concerns are mostly with regards to the pain of the injection site. It can be painful. The knee is actually the least painful of the ones that I've had. A big joint, right? So there's plenty of space, and the amount of fluid that goes in doesn't cause the joint capsule to feel like it's going to burst like a balloon. The little joints, especially the fingers, can be very painful, but I believe that 10 seconds of pain can be better than 10 years of pain, and that was the case for my left knee. Frequency, the rheumatologists tend to have a different guideline around this depending on the current quality of the joint, cartilage, the amount of cartilage you have in a joint, but no one's really getting them done more than 4 times a year in a single joint, and it's closer to a couple of times, 2 times a year in a single joint. But again, talk to your doctor. Infections are rare, and the systemic release of the steroid we've talked about.
Alternatives. Hydrolytic.
This one's a hard one. Hyaluronic acid.
PRP, ozone.
That's right. So there are some alternatives to cortisone injections. One of them is this hyaluronic acid. I've never had that injection. People with rheumatoid don't tend to get it. Why is that? It's because it's suitable to give you an extra 6 months, 12 months, maybe 18 months if you've got an osteoarthritic knee that needs a knee replacement. With rheumatoid, there tends to be lots of inflammation in the joint, and therefore it's not a great option, but talk to your doctor about it. It may apply if your knee in particular is low in inflammation. Next, PRP joint is platelet-rich plasma injection, and these tend to be don't have as many risks associated with them in terms of cartilage degradation. That's an option, but again, when a joint's inflamed, talk to the doctor about that. And then ozone I've listed here for completeness. Ozone can be a great intervention in a joint which is nearing end of life, that doesn't have inflammation, and is in a body that has low inflammation. It's a bit of a complicated reason for that, but ozone stimulates some oxidative stress. The body can adapt and generate some antioxidants which can assist with cartilage development. And I've seen some medical professionals present ozone intervention before and after x-rays online, and some of them are very impressive, but it's something that you would again need to investigate. The doctor who is excellent in this area is based in California, Dr. Robert Rowan. You can Google him if you're interested in looking at some before and afters of ozone-treated joints. But remember, it's a little bit dicey when it comes to rheumatoid because there's already so much oxidative stress in the joint. So personally, I don't recommend ozone for inflamed joints. So we are up to the
last one.
That's right. And
the last one is summary.
The summary. So what we've established is that the intra-articular cortisone injection can be a great idea if you've got one or two joints that are outliers, ones that aren't responding to all the natural things that you're doing. The science says that they're safe, whilst we are aware that there is a problem if you have them too often. So your rheumatologist won't allow that, or should be monitoring that. And there can be some cartilage degradation as a result. So it's whether or not one injection from time to time is worth the little bit of pain and also the little bit of cartilage impact. And in my personal view, if you're suffering very chronic long-term inflammation in that joint, that is a wise thing to investigate with your doctor, rather than knowing your joints are being impacted so much by the inflammation. Again, only when there's one or two joints impacted, because if multiple joints are inflamed, you're better off talking about a disease-modifying drug or a biologic drug. So, Angelina, any questions that you have after going through this?
No.
Thanks very much for helping me out with this video. Would you like to do another one in the future?
Yes.
Well, thank you very much. Hopefully this helps everyone. Say bye-bye.
Bye.